So to finish out our morning session, I'm truly honored to introduce Dr. Sue Borson. Dr. Borson is professor part-time of clinical family medicine at the University of Southern California, professor emeriti at the University of Washington, where she developed its memory disorders clinic and led the ADRC's diversity recruitment efforts, and where she developed the mini-cog. So here is the founder of the mini-cog to speak to you. Her work focuses on strategies for improving dementia detection and care delivery, caregiver self-efficacy, and the use of health system data to improve dementia care planning. She co-leads the CDC-funded BOLD Center on Early Detection of Dementia at New York University Langone Medical Center and the Southern California Dementia Care Improvement Network. She'll be speaking today on early detection of dementia toolkit developed as part of that project. Please welcome Dr. Borson.
Hi, everybody. Okay, great. I have the honor of having the best position of the morning, which is the one right before lunch. So I don't know about you, but I'm pretty tired.
Okay, are they showing?
Nope, they're not showing us slides. Well, we need slideshow, number one.
Oh, that would be.
No, okay.
It says end slideshow.
Yeah, well, you want to end it and that starts it? Is that what?
I don't know.
No.
I told you, I'm a technology dinosaur.
There we go. Okay, so I'm going to try to be quick and maybe add a couple of pieces of philosophy to this whole thing. The entire point about detecting dementia is so that you do something about it. That's really the whole point. And that's been part of the resistance to doing dementia detection in a widespread way in clinical settings. People don't know what to do with it. So the little piece of addition that I want to add that isn't really yet part of the BOLD Center, I hope it will be one day, is that there are pathways of care that are supported both by Medicare and Medicaid, and there are also concepts of care that have yet to be better developed. And those concepts of care are very much multimodal, interdisciplinary, multiple, and that's what makes them hard to implement. But I'm going to give a plug for the 6 domains of health, which is my way of talking about complicated care for older adults, whether or not they have dementia. And that 6 domains of health is the foundation for a curriculum for nursing students and practicing nurses, which we hope to roll out in the fall, and eventually to transition to other health disciplines besides nursing. But I'm here to talk to you today about a public health approach at the national level. So the BOLD Centers of Excellence in Dementia, funded by CDC, were convened to be knowledge aggregators, to bring together information in 3 major areas that are pertinent to dementia. The first is risk reduction. You might think of it as prevention, but mostly it's risk reduction, shaving off heightened risk by changing modifiable risk factors. The second is early detection. That's the center that I co-lead with a geriatrician who many of you know, Josh Chodosh, who was here in LA for many years and has been at NYU for some time now. And the third center is the Center on Caregiving, which is housed at University of Minnesota under the leadership of a gerontologist, Joe Gogler. So these three centers all collaborate at a national level to bring together expertise, knowledge, and tools to make it easier for people to develop concepts around risk reduction, early detection, and support for caregivers. In our center, in the Center of Excellence on Early Detection, we focus on 3 sectors: health systems, which is where Josh and I really have been embedded over many years, departments of health, and community-based organizations. So our 3-sector model pervades everything that we do and think about. And I think it echoes what Tony Kuo was talking about this morning, about how crucial the multi-sector approach to dementia actually is. So here, I don't know if you can actually see, oh, where are we? Okay. Yeah, if you can see the little boxes down below. But this illustrates what we're trying to do in the different sectors. My topic today, though, is about the toolkit for healthcare delivery. We call it a health systems toolkit. This first iteration of it, which was just recently co-branded by CDC and launched on its own website, which makes us very proud, means that CDC thinks this is important and a national contribution. So we feel good about that. But what it is in this iteration is really a conversation guide for docs and other healthcare providers, how to broach the subject of cognition, how to introduce the idea of the importance of screening for cognitive impairment, and how to make it user-friendly for doctors, patients, and families. In this toolkit, we have lots of different tools. I want to touch on a couple that we don't deal with, or an approach that we don't deal with yet, but will in subsequent iterations. And that is, we're talking now about detecting dementia that exists. We're not talking about detecting dementia risk, per se. There are lots of ways of detecting dementia risk through analysis of electronic health records, as Heather was talking about, and others. But the emerging science here, which you're going to be hearing more about this afternoon, the emerging science is about biomedical measures of risk for Alzheimer's disease. So I want you not to consider that all dementia is Alzheimer's. Alzheimer's disease is a unique cause of dementia. It is common, yes. It is age-related, yes. And in case you didn't know already, who's aging in this right here? We're all aging, and we hope to live a long time, and we hope to live healthy for a long time. But be that as it may, let's come back to the idea of biomedical risk, which will be touched on more this afternoon. We have blood biomarkers now. We've had imaging biomarkers for some time, looking at the brain using PET scans, most particularly. And we now have, there's a fascinating new article. I want you to know about this. It's not part of my regular talk, but I do want to tell you about it because it's so cool. So there is a group in the US and Canada that has developed a little gizmo that you plug into your onboard diagnostic portal in your car that will measure your driving behavior while you drive, and you don't know anything about what's going, you don't know, it's not bothering you, you're not needing to pay any attention to it. It's going to pick up how you're driving. Your lane changes, your sudden jerks, your unexpected stops, your speeding, and all that kind of thing. Well, interestingly, the use of this little tool, after heavy data processing using AI, machine learning, and so on and so forth, this little tool actually increases detection of biomarkers for Alzheimer's disease in the brain. Isn't that interesting? That is very interesting. There's a lot of promise in tools like this. So I just wanted to mention it because it's so cool. Back to why early detection matters. The fundamental reason that early detection matters to people is so that we can do something to help, to shave off excess disability, right? To make it easier for people to live well, even though they have dementia, and for caregivers to get the help and optimism and support that they need to be able to carry through as long as they need to. So this is our pre-screening conversation, how to prepare for a cognitive screening. It's as important as doing the screen. You don't want to just sit people down and say, hey, I'm going to screen you now for, hey, dementia. It's like, how are you doing? Are you having any concerns about your cognitive health, about your memory, about being able to do things you used to do easily every day? Very simple kind of primary care kind of conversation. So tell me how you are, create time and space. Know what to say to people if they have problems, and use short, simple statements because they ease fear and worry. A lot of people who don't want to be screened for dementia don't want to be screened because they're scared. They have a very scary idea about what dementia is, about what Alzheimer's is. And unfortunately, I think that some of us as specialty professionals are a little bit to blame here. that in our desire to make everybody understand, wow, this is a real thing, it's important, it really impairs people's lives. In our zeal for this, we have scared people half to death and given the false impression that anybody with dementia is gonna be a vegetable. You know, how many times did I hear in my memory clinic, I don't wanna be a vegetable. I don't want to talk about my memory because you're gonna take away my driver's license. You're gonna put me somewhere, aren't you? And I was forever saying, no, I don't have the power to do any of this. I am not doing this. What I want to do is help you make your life better and figure out whether or not your brain health is a piece of this. Let's develop a plan together. Let's decide on next steps. So in our toolkit, we talk about what is the difference between detection, assessment, and diagnosis. I'm not going to go into that because I think all of you understand this pretty well, but I want to emphasize a concept here, and that is that when you use a simple screen, like the MiniCog, which, by the way, works shockingly well across educational groups, ethnic groups. I never expected that it would work as well as it does. It isn't perfect because no screen finds all cases, and no screen avoids calling it impairment when it isn't. There are false negatives and false positives for all screens. But the MiniCog, shockingly good at doing the job we want it to do, which is to give us a signal that there's a problem. I would rather have a signal in my primary care clinic that somebody has impairment than have that first signal be a hospitalization for an avoidable medical complication. Wouldn't you? Wouldn't you rather know when you can do something to prevent that than discover, oh my goodness, dementia, this person has dementia because they were admitted to an inpatient facility for a preventable complication of that dementia. Okay, so MiniCog and other tools like it are signal detection devices. That's what they are. They aren't diagnostic tools, and they are not really assessments. An assessment of cognition is more complicated, and it involves more cognitive evaluation, usually more difficult tests if needed, not always needed, and functional evaluations and medical evaluations that lead ultimately to a decision. Is there impairment, yes or no? If there's yes, how bad is it? And what is the likely cause or set of causes that might be playing a role? And what do I need to do to work with this person to help? So a diagnosis really is an attribution of cause. And screening tools don't do that. Biomarkers for Alzheimer's disease can be used as screening tools, but what they are is screening tools for biomarker-based risk. They are not screening tools for dementia or Alzheimer's disease. Sorry. There has been a change very recently, a very controversial change. You may have seen an article in the New York Times about this, featuring a geriatrician who's been very thoughtful about the problem of defining Alzheimer's disease on the basis of biomarkers alone. If you have a positive biomarker, A beta 42 to 40, or p-tau 217, or something like that, these high-tech biomarker tests detect these substances in the blood, and they are associated with future development of Alzheimer-type dementia. We now are supposed to define Alzheimer's disease as the presence of a positive biomarker, whether or not a person is cognitively impaired. And that's where the controversy comes in. A lot of clinicians are very upset about this. How do you have a disease if all you have is a test, in a blood test, while you're showing none of the manifestations of the disease in your life, namely memory loss and other cognitive disabilities? So this is going to be an area where our Bold Center is going to have to do some digging and some public education about this. Okay, so we give in our toolkit some screening tools. They are cognitive screening tools and they are functional screening tools. Both are important in the identification of people with cognitive impairment in actual practice. You need both. And the cognitive health assessment under Dementia Care Aware does both. Okay, what should you do after detection? We have some suggestions, again, for how to talk about it. There are many places you can find what should I do medically, what should I do, what tests should I do further to take the problem from a screen positive to something more definitive, like a diagnosis. We are not going to replicate what everybody else has already done, which you can already find in many places online and in the literature. So we're really going to be talking about things in a more general way, and this is coming next. Not next in this talk, but next for us in the Bold Center is to develop a kind of a different approach to what do you do after. So it's, again, how to talk about it, how to make it possible for people to tolerate what you're hearing. What does screening mean? What does a result mean? What doesn't it mean? A normal result on a screening test does not mean you don't have impairment. If you think you have impairment, I better listen. So that's something else, that's another take home for you guys is anybody who is complaining about their cognitive function should be taken seriously, no matter what they do on a screening test. Okay. So do a basic evaluation, explain the results to the person, bring the conversation into life context. How is this affecting you? What would you like to be able to do now about this? I can give you some advice about it, but I'd like to know what you think is important for you. Well, I want my daughter to know, or I don't want my daughter to know. Let's talk about that. Why don't you want your daughter to know? Well, because she's going to treat me she's going to treat me as somebody who can't do anything. And we already have conflict. Okay, well, let's get your daughter in here and let's talk together about all this. This is the kind of thing that we want to promote as a center. Most people with dementia, most people with a cognitive screen positive result do not need a specialist. Not a bona fide cognitive disorder specialist. Many kinds of specialists, yes. Maybe a primary care doctor who specializes in whole person care. Is that a specialty? I'd like to think of it as what is just what we do, but it often enough isn't just what we do. And so that's what we want to promote, is this is a whole person care approach. So there are specific times when a specialist is required. And I'm a specialist, I mean, I can understand, but as a leader of a memory clinic at University of Washington for many years, what I most often saw was people who didn't need me. I had a lot more specialized expertise than they needed. They just needed a good primary care doc who understood they had impairments and how to work with that. And that, I think, is a message that isn't going to get old very quickly. Okay, so what we're going to be talking about in our next iterations of our toolkit is really going to be crisis prevention, because this is what we think is very important in dementia care today. Crises in dementia care occur along many pathways. I mentioned earlier the 6 domains of health, right? Cognition, mood and behavior, neuropsychiatric symptoms, medical problems, comorbidities, medications, medical treatments, caregiver status and needs, health-related social needs, healthcare and social system organizational factors, 6 domains. Crises in dementia care originate in any one of those 6 domains. And one crisis in a single domain usually leads to a cascade of crises in other domains. So this is the concept that we wish to develop to a greater degree and make it more practical for people to use. We can talk about the guide model over lunch if any of you have questions about that. A number of us could be answering questions about care navigation within healthcare systems. I'll mention in that regard that I have some heroes who are Canadian primary care researchers who focus on dementia. And they have recently published a paper in which they show that, first of all, continuity of care with a primary care doctor is associated with much lower rates of hospitalization and preventable hospitalizations than low continuity with a primary care doctor. That's a really important finding. There's also a group in the States, a couple of groups in the States that have done this, done similar kinds of work and made related, fairly similar findings. The same Canadian group, though, recently compared patients with dementia who were cared for in a team-based setting, nurse, social worker, other support staff, and those who were cared for in a primary care only clinical setting. And found actually that people in team care had higher rates of emergency room visits than people who were in physician-only practices, which is a surprising counterintuitive result, and one that I hope to see them follow up on, because what does it mean? They wonder whether what it means is that in team-based care, more problems are found earlier, and so people are using more health care. They're getting to the emergency room instead of staying at home, not knowing that there's a problem. Not sure, they can't really argue that with data, but it's an important consideration because everybody in primary care is saying we need teams. We all need team care. So to me, that result says the following. What we need is teams, but to match those teams, we need a really good idea of how teams ought to be working together. The team members need to be doing specific jobs. What are they? And how do we get them working together so that we all have the same goal? And for me, the best way I found to express the goal that I have isn't quality of life, because I don't know what it means. I don't even know what my quality of life is. I don't know how to describe it. It's crisis avoidance. It's preventing crises, those disruptive events that lead too often to kind of a downhill slide for everybody involved in the care of an older adult. So crisis avoidance, crisis prevention, to me is a kind of a beacon guiding my thinking about how we should be organizing our teams. And that requires that we have a multidimensional approach to what team function is and what who is going to do what. Okay, so we have in the pipeline 2 more toolkits. We have the health system toolkit that we've already put out with CDC's approval. We have ancillary documents that we're preparing now for truly for health systems, healthcare organizational leaders, ways of organizing care within healthcare systems, whereas previously we were talking about early detection and talking to people, right? Now we want to change healthcare, assisted very, very importantly by Dementia Care Aware and the leaders in that program. So we'll be doing those additions to our health system toolkit. But we're also developing a toolkit for community-based organizations and for health departments regarding early detection of dementia. So I want to kind of come to a close by asking you, how many of you are involved in, or how many of you are aware? Let me ask it this way. Aware of dementia friends? Hands up. Okay, great. How about dementia-friendly communities? Hands up. Great. How many of you are actually active in a dementia-friendly community? Okay, not so many. Okay, so I'm a little surprised by that. You're very aware, but you're not embedded in a dementia-friendly community. So dementia-friendly communities are seeds. They're seeds for community-based care that can link people to healthcare and to public health education efforts. So the idea that we can seed public awareness by using dementia friends and dementia-friendly communities is something that I'd like to leave you all with. It's something that I would like to see us in the Southland promote throughout our county. My county is Orange County. I want to be promoting this in Orange County. In LA County, dementia-friendly communities could be your friends and your partners in this endeavor. So, with that said, I want to free you all to stand and stretch and go to eat. Thank you. If there are any questions, I'm happy to take one or two, or comments. Questions, comments? Nah, didn't think so. Yes, there's one. Okay, I hear you. Yeah, what? Okay.
You had mentioned, by the way, phenomenal presentation. You had mentioned ERs. I'm just curious, the importance of making sure that there's a mini cog or some type of test that can be done in the ER, just because there's so many that are missed. Just curious in your impressions and your thoughts.
Oh yeah, so the emergency room is a unique situation, right? So what do we know about it? In brief, we know that people with dementia have very high rates relative to age mates of using emergency rooms, right? We also know that repeat visits to emergency rooms are much more likely in people with dementia. So we did a little study in New York. It wasn't actually so little. It was a 2-site study, one Indiana site, one New York site, in emergency rooms to try to, we screen people for dementia in the emergency room, and then we randomize them to care management upon discharge or not. And we got no effect of what we did. Now, we're very busy trying to understand why we got no effect. I think we have a pretty good idea. My own bias is why we got no effect is that our care management was not embedded in primary care. It was not embedded in the patient's own health care. And I think that was probably our flaw, our major flaw. But that study now led to a new study, newly funded by NIA. 80 different emergency rooms around the country are all participating in a dementia care management program initiated at the time of discharge from the emergency room. This is not a screening study. It's not a detection study. It's anybody with a diagnosis of dementia already who shows up in the emergency room can become a candidate for this care management randomized trial across 80 different emergency rooms. So trying to get change to happen in the emergency environment, I'm sure your question comes from a place of knowledge, that it's very hard to make changes in a fast-paced, high-intensity, all-comers, what's going to hit you next kind of environment that characterizes emergency departments. So I think that's a work in progress. I'm curious if you have a comment of your own about how to do this.
I've seen, I was up in Oregon. I was up in Oregon attending an Alzheimer's Association meeting. There was a gentleman up there from OHSU, and they were doing a study very similar. And one of the things that had come out was those individuals of Medicare age, how many of them that they actually went in to the ER, they were high utilizers, and it turned out that they actually had dementia. And what they were doing to try to connect them back to their community-based physician, but more so than that, in order to be able to initiate something as quickly as possible in order to be able to take care of this.
Right, and so once again, I kind of come back to the what is taking care of this. That emergency room visit was a crisis, right? I define an ED visit as a crisis, a hospitalization as a crisis, because its effects are usually of that proportion, some kind of disruption that is more likely to be harmful, or it carries harm with its benefit. So it's a double-edged sword. So if we really want to prevent these kinds of crises, and by the way, we haven't really been able to show how to do this. This is very hard to do with older adults in general, who are mostly, if they have dementia, they also have multimorbidity. They have all kinds of problems, hence 6 domains of health. If we really want to impact our crisis events, I think we have to start to think that way about what are the different domains of health that are intervenable on, if you will. We have one paper about this model that's already been published, it's a small pilot study of 88 people. And we have a chapter in a nursing textbook on palliative care, oddly enough, not meaning all dementia care is palliative. Okay, right now, we're not talking cure no matter what. We're talking about palliation. So we have a chapter really delineating what this model looks like, as well as this peer-reviewed publication. I hope that we'll be expanding our data set on this in the next couple of years by quite a bit. So it'll be possible to articulate better what are the problems in each domain that lead to crisis, and what are the interventions within each domain that we need to be doing. And if you intervene with a caregiver, do you really improve the health of a person with dementia? And if so, how does that work? So this is I think where we are in the big picture of clinical care and as it shades into population-based health. Thanks for your question. One more, yeah.
I'm Sahar. I'm one of the internal medicine primary care doctors at all of you, and one of the champions in our clinic trying to detect, follow up on some of our positive screens with Freddie and a multi-center grant that we're part of. So I think you mentioned about the primary care role and how we can do this. One of the things that we're realizing, as I think everyone knows, is just the limitations in time in primary care. And just part of the reason we refer out is just because we don't have the time to deal with it. Not that we can't, we just don't have the time. How do you think as a system we can advocate for more time for primary care doctors to deal with some of these things?
Right. So this now gets very quickly into the problem of political argument, right? If you read the literature the way I do, you know that profit motives in healthcare delivery systems have become increasingly visible, maybe not increasingly compelling, but increasingly visible. And why is it that doctors don't have enough time? Well, they don't have enough time because they have to meet productivity standards on which they are graded, and those productivity standards have to do with the generation of billings. These are things that we know. We understand this. And so we understand this, but we don't know how to interact with this in a way that is constructive. I think that's where I would land on this. So we talk about developing geriatrician champions, really, because it's getting the champions into higher levels of healthcare administration is a very important step here, because geriatricians have the passion for this, and for care as a group, as do primary care docs in general. I think about geriatricians as primary care docs for old people. So I think that the politics of this is really where we have to land. We have to be thinking about the politics. I know that the Academy of Family Practice nationally is very engaged in the issue of funding and team-based care, but we haven't cracked this nut, and I don't know how we do it. So I think there's a place, and an important place, for maybe even just an idea sharing group about this, to gather people's ideas about how to fight back. You know, for me, the time pressure is the crucial piece. That is, it intersects with the EHR burden piece. It intersects with the problem that healthcare systems come back with, which is access. We need to guarantee access, and so we're balancing access and individual visit times in ways that are driven by the healthcare system and prevent us from spending the time we need to spend with any given patient. We don't, you know, some people need 5 minutes. Some people need an hour, but we're limited to 10 to 15 to 20 minutes. So it simply doesn't really compute. So if anybody has ideas about kind of an action step that we might take as a collective, you know, we're talking collective action here, really. Let's talk about it over lunch or through the afternoon, see if there's enough interest in this type of problem that we could maybe launch a conversation together about it. I think it's absolutely crucial, and we can't deal with these very fancy ideas that we've been sharing all morning. We can't do it without making changes in healthcare delivery systems. Heather, yep.
Is there time? Is there any time? Here comes some.
Thank you for waiting.
Thank you so much. Sue, thank you for that question, Sahar. I don't want to sort of completely dominate talking about primary care, but I know it's near and dear to your heart. I was just wondering if another solution and how you might see this solution could be helpful around AI, artificial intelligence, and I've really been interested in how we can help patients and families and communities sort of better self-identify and self-report.
Right.
And I want to make sure that we also address things like the digital divide and other sort of health inequities that might play into the use of technology.
Was there a question?
Yes.
What are your thoughts on technology for
Oh.
detection of,
Oh, yeah, okay. My thoughts on technology are, yay, technology, yay, AI, but watch out. Those are my thoughts. So I'll mention to you that one tech application of the mini-cog, by the way, I did create, or a high school student who worked with me did create a mini-cog you can take yourself on our website, but I'm not advocating it. It hasn't been validated. But there is a company that has digitized the mini-cog. They call it DCR, dementia, or digital clock and recall. So they've digitized the entire thing. Can be given by an administrator. They are embedding it in a platform that will include other evaluations, easy to apply, and they have been testing it in various practices, a few practices. They are currently really eager to test this in primary care. It's a little bit more difficult than doing it in specialized like neurology clinics. But that is one approach. There are other tools. There are self-assessments you can do online through Us Against Alzheimer's. That's one resource for self-testing. There are lots of other ways of doing this, but I think the message that I need us to focus on, I think as people concerned with the individuals who are living with these problems, is what do we do within our own sector to be able to do a better job and understand more about what the job is that we are trying to do. Hence the beacon of light toward crisis avoidance and crisis prevention. It's really great that we have the treatments that we're going to be hearing more about this afternoon. That is great, but that is not a population solution. Not anytime soon. So we have to be working at both ends, from the ground up and the top down, heaven down. And I like to think of us all as being part of that heaven down cohort. Thanks very much. Okay.